Hello, everyone. I'd like to welcome you to the AJT Journal Club mini-series. My name is Josh Levitsky. I'm a transplant hepatologist at Northwestern University in Chicago. And I'm joined today by my co-moderator, Alberto Sanchez-Fueo at King's College in the UK. And we have two speakers today and also joined by two colleagues that are going to be presenting two papers on TCMR and liver transplantation. I just want to give a little bit of an introduction to this mini-series. This was an idea by Dr. Feng to have kind of a novel way to present papers in the American Journal of Transplantation to the AJT audience. And the way this has, the format of this is that there'll be a theme for each of these mini-series, and it'll rotate between different organ systems or different areas that are going to be focused for different mini-series webinars. And so the topic for the first Journal Club mini-series is in T-cell mediated rejection in transplantation. There was already one that was recorded in kidney transplantation a few months ago, led by Roz Manon, that was very well received. And today we're going to be focusing on liver transplantation in TCMR. What we're going to be doing is presenting, having the authors of the paper present their papers in this pre-recorded session right now. And that will be recorded and spread out to the membership. And we'll be having two webinars down the road that will be a bunch of panelists who are going to be discussing the papers and the presentations, and this will be open to the AJT audience. And so just to kick this off, the two papers that we'll be discussing today are, the first is molecular diagnosis of rejection and liver transplant biopsies, first results of the INTER-Liver study, and Dr. Philip Halloran, who is well known to all of us, will be presenting, and the first author who is listening in today is Caitlin Medill-Thompson. And the second paper is entitled Outcome and Safety of Surveillance Biopsy-Guided Personalized Immunosuppression Program After Liver Transplantation. And this will be presented by Richard Taubert, and Elmar Jackal is on today, who was part of that paper. The webinars going forward will be, we don't have exact times yet, but we'll have panelists from around the world discussing these two papers in a live session. And there'll be two live panels. The first one will include Jake Dimitris, Eleanor de Martin from France, and Maria Ladano from Spain. And the second one will have also Jake Dimitris, Nancy Kwan Man from Hong Kong, and Jeffrey McCann from Australia. And so we're really excited for today, which will be focused on biopsy-guided approaches to patient management with these two papers. I'd like to ask Alberto to just give us a little bit of context as to why we selected these papers and the evolving interest in biopsy-guided approaches in liver transplantation.
Yes, thank you very much, George. So the reason why we chose these two papers is because we think that they raise extremely relevant issues in what regards the long-term management of liver transplant patients. For instance, what is the utility of molecular profiling in the setting of liver transplantation remains kind of an unanswered question. What does molecular profiling teach us as to the immunological uniqueness of the liver allografts? Are protocol biopsies actually really relevant to the long-term management of liver recipients, and could we potentially obtain similar benefits from using non-invasive biomarkers. And ultimately, we hope we will be able to derive some sort of evidence-based guidelines on how to manage immunosuppression in the long-term care of our liver recipients. So without further ado, I will kind of let Dr. Phil Halloran present the first paper, and we hope that you will all find this session interesting. Thank you.
Well, thanks for the opportunity to present this. We'll be talking about the molecular diagnosis of liver transplant biopsies as we're seeing it in the INTERLIVER study. And I'd like to thank all our many co-authors, some of whom are on the call. These are my disclosures. And this study is supported in part by a research grant from One Lambda Thermo Fisher. The people who worked on this are shown here, and I'd particularly like to pay tribute to Dr. Caitlin Madel-Thompson. So the molecular microscope system is a central diagnostic system that uses genome-wide microarrays to measure gene expression and compare the biopsy to a reference set using ensembles of machine learning algorithms. So we measure approximately 50,000 probe sets, and then we use the machine learning to interpret the disease states. And we're looking at T-cell mediated rejection, antibody mediated rejection, including the stage of antibody mediated rejection, but we're very interested in the parenchymal changes because actually that's what keeps the patient well, the parenchyma. So we're looking for recent injury, irreversible injury, steatohepatitis, and we're trying to predict progression. Now, our approach is that the true disease state is never really known. We're always discovering, and this is a discovery project. Now, we have conventional assessments which approximate this throughout medicine. The molecular assessments give us an opportunity to use many different algorithms. We use ensembles of algorithms to estimate the disease states. And the goal is not to agree with any particular platform like histology, but to discover the molecular states and to understand them at a different level, and to then see how well our conventional systems agree with the molecular states. Now, in liver transplantation, T-cell mediated rejection is usually diagnosed by histology, and there's moderate agreement between observers. But obviously, all conventional systems have to take a certain approach, and it's not to be taken as the gold standard truth, nor is molecular. We're always looking at new platforms. Antibody-mediated rejection has been controversial in livers, and donor-specific antibody testing is not standard of care at many major centers. And given the advantage of molecular diagnostics that we've seen in kidneys and hearts and lungs, we wanted to look at livers. Livers present some unique challenges. So this is the method we use. So the participants send us a piece of tissue in case we get about 5 millimeters of a liver core. And the liver core gives us enormous amounts of RNA compared to the other biopsies we receive. So we receive this usually overnight by FedEx. We extract the RNA, we put a label on the RNA, and then we hybridize it to the chip. We develop the label, and then this is translated into basically a spreadsheet. And our algorithms then turn that into a report. So the biopsies were collected here from 10 international centers and shipped to Edmonton and hybridized to the PrimeView chips. And the standard of care clinical data was reported by the participating centers via REDCap. Our approach was to use unsupervised analysis in this first set of analyses in the paper. And this is based on the rejection-associated transcripts, which have been frequently published in kidney in AJT. The rejection-associated transcripts were derived by their associations with antibody-mediated rejection, T-cell-mediated rejection, or common to all rejection. And then the transcripts are, what we usually do is we IQR filter them to make sure that they have variance across the livers or the hearts or the lungs. Now, we use principal component analysis to ask a question to see if the liver and its relationship to rejection-associated transcripts was similar to the heart and the kidney. This gives us an unsupervised look. So when we look at the kidney or the heart or the liver, we're distributing all of the rejection-associated transcripts and looking at their expression in principal component analysis. And principal component 1 is rejection, and in kidney and in heart, principal component 2 is antibody-mediated rejection versus T-cell-mediated rejection. So when we do that in the kidneys and the hearts, we get 2 components of rejection. We get the blue component, which is antibody-mediated rejection, separating from the red component, which is T-cell-mediated rejection. When we do that in the livers, we don't get that separation. We really are only getting 1 component, principal component 1, and the genes which are associated with antibody-mediated rejection in the kidneys and hearts and lungs, in fact, don't seem to have that kind of variance in the liver transplant biopsy population. So this is our first sign that perhaps antibody-mediated rejection would not pop out using the approaches we'd used in the other organs. Now, the other method we used, archetypal analysis, which is a clustering method in which you distribute the biopsies in data space by their expression of a particular feature, in this case, the rats. And then we group them, and you have to choose a number of groups which best fits the data, and we chose 4. And every biopsy is then given a position in data space and is actually assigned to a group by virtue of its closest relationship to the archetypal center of that group. And we have found in the other organs that this gives us clinically relevant groups. So now when we do this in the livers, we get 4 archetypes. And so we're looking at principal component 2 versus principal component 1, and then we're rotating that cloud of data, and we're looking down the barrel of the cloud, so we see principal component 3 now separating. So principal component, so in the archetype 1 turns out to be really very normal biopsies. The archetype 2 turns out to be biopsies with a heavy T-cell infiltrate and gamma interferon effects. And that looks like T-cell mediated rejection. Principal component 3 is early injury in the livers. And then we have archetype 3. Archetype 4 is a very small set of biopsies. We won't talk about that very much because it's really too small a group to be certain about. So that's where that maps in space. And then we separate that in principal component 3. So this is the rotation of the cloud. So there's something different about this 4th group. Now, when we look at genes and gene sets in these different groups, archetype 1 is characterized mainly by very low expression of the rejection-associated transcripts. And it has a lot of high expression of the normal features of the liver. Its median time post-transplant is actually very long. It's as if the normalness takes a long time to emerge in the transplanted liver. The archetype 2 is a set of TCMR biopsies. They have high expression, especially of the T-cell receptor genes, actually, and also some gamma interferon genes. It's a little bit different from what we see in hearts and in kidneys, and I could come back to that. The median time is a little earlier than what we see in hearts and kidneys, too, at 214 days. Archetype 3, the injury archetype, has high expression of many transcripts previously associated with injury in kidneys and hearts, like SERPINA3, and its median time is fairly early. So here's what we see in terms of the time relationships. The scores are plotted here as moving averages. So the TCMR score is very early and gradually subsides over the first 2 to 3 years. And then we don't see this phenotype late. The injury score, which is in blue, is the earliest score. It's very high in the early biopsies and then regresses. And again, we never see this in the late biopsies. The normalness score is very low initially, and then it rises, so that normalness is a feature of the late transplant biopsies, at least as looked at with the rats. So we've got two regressions in TCMR and injury, and kind of going in parallel, which isn't the usual picture we see in kidneys and hearts. And then we have the emergence of normalness. When we look at the biochemistry from liver function testing, we see the normalness obviously has excellent expression of albumin, low expression of the abnormal liver function tests, and a long time post-transplant. The TCMR and injury and the late phenotype have various high abnormalities in their liver function tests. So again, unsupervised clustering of the biopsies has produced groups which correlate with liver function test abnormalities. And there's a reasonable correlation with histology. Now, remember that histologic classifications generally have some disagreement between observers. This is common in any pattern recognition, the visual pattern recognition system. So we don't expect high agreement, but this is reasonable agreement between the molecular assessment of T-cell mediated rejection and the histologic assessment. So this is our MMDX sign-outs compared to the histologic sign-outs. And when we looked in detail at histologic features, it was satisfying to see the histologic features which correlated were those which we would expect in liver T-cell mediated rejection. So I think at this point we could just summarize. MMDX liver finds early acute rejection TCMR is common in liver transplant indication biopsies and becomes quite rare over time. And this strongly suggests to us T-cell exhaustion. Perhaps this is related to the tolerogenic properties of the liver. Interesting as earlier and somewhat different from what's seen in kidneys and hearts. And molecularly, there are some differences as well. We don't see as much expression of the checkpoints. The MMDX TCMR correlates with histologic features, and there's no distinct ABMR phenotype. And this could be because ABMR is different, it doesn't use the same genes, or because it's rare, or because the liver is just so massive that it absorbs the antibody and it's resistant to the antibody. But we kind of suspect there will be an ABMR effect. We're looking at that in different ways now. And the discrepancies are similar to what we've seen, for example, with heart transplants. And this approach, I think, shows promise for discovery of mechanisms, but also for use as a diagnostic system to enhance our understanding. Just like to point out, this is the abstract, but that the other aspect we're looking at is the parenchymal aspect, and AJT has our first paper on the diagnosis of steatohepatitis and fibrosis to complement this. So thank you very much.
So I would like to introduce now our second speaker. This is Dr. Richard Taubert from the University of Hanover, who will be discussing the benefits of protocol liver biopsy scheme to potentially improve clinical outcomes. Thank you very much, Richard.
So thank you, Alberto. Just start the presentation. Okay, so first of all, I want to thank the editorial team to choose our paper on outcome and safety of an individualized immunosuppression approach guided by surveillance biopsies after liver transplantation. I present here also for my co-senior author, Elmer Jekyll, who just moved to Toronto from Hanover Medical School. And the starting point for this whole program was the launch of the surveillance biopsy program in 2008. This was started by Elmer Jekyll at the beginning, just for research purposes. And after a few years, we had enough biopsies to really see effects. And this is just a summary of a brief report we did a few years ago, just on surveillance biopsies with no relevant elevation of liver enzymes. And we saw that over time, 20 to 40% of the patients exhibited no relevant graft injury in the biopsies according to the 2016 BANF criteria that allow minimization of immunosuppression, probably in a safe way. But on the other hand, 50 to 60% of the patients had any kind of relevant graft injury, in terms of subclinical TCMR means the pathologist sees patterns of TCMR, but the liver enzymes are not very elevated or normal. And we see indeterminate findings according to Banff in terms of TCMR. And on the other extreme is that 20% of the biopsies already had any kind of advanced fibrosis or even recirrhosis. And having these data, we somehow had the feeling that we have to include the information we got from the biopsies into our management of the patients. This is the schedule we, and especially Elmar, came up with, that we start with a more or less standardized immunosuppression in the first years, with some exceptions for reduced kidney function, HCC or CMV reactivation. We included everolimus already in the first year. It's an mTOR inhibitor that was approved for the use after liver transplantation in Germany a few years ago. And then after the first year, we incorporate the finding of the surveillance biopsy, as shown here by Emily Saunders, who's the first author of this paper. And if the surveillance biopsy has no relevant graft injury, we assume that's a low rejection risk. We reduce the immunosuppression from the level the patient had at the biopsy stepwise. And I'll show you more on this on the next slides. If the surveillance biopsy showed an intermediate rejection risk by some relevant graft injury, but without donor-specific antibodies and without advanced fibrosis, we keep the level of immunosuppression from the first year even until the next years and would not reduce the patient just by the time point after transplantation. And if we see advanced graft injury, means relevant graft injury in terms of inflammation plus donor-specific antibodies that are associated with upregulation of rejection-associated transcripts and other previous projects, or already advanced fibrosis, we increased the immunosuppression. And in terms of advanced fibrosis, we included everolimus because there were some encouraging data that everolimus or mTOR inhibitors might have an antifibrotic effects. We do this immunosuppression management in a kind of a structured conference once a month. And the aim of the study was to see if this single center clinical approach is beneficial and safe for the patients. We used the first 2 to 3 years from end of 2018 to autumn of 2020. Since this was no randomized or controlled trial, we had to use a historical comparator cohort. We decided to use patients that received a surveillance biopsy just until the beginning of this program, but without the structured assessment we started in 2018. The parameters we used to describe patient safety and the benefit of the program was graft injury with longitudinal assessment of liver enzymes, liver stiffness, and of course, the worst scenario of a biopsy-proven acute rejection. The short-term benefits are best monitored by kidney function. We use a fold change of the eGFR starting from the baseline at the time point of the biopsy, and we had a short to medium-term follow-up, as I will show you on the next slides. In this 2 to 3 years, we had up to 300 biopsies of nearly 300 patients. We had luckily 0 procedural complications, means no bleedings, no biliary complication, no infection or whatever. In the previous study from our center with 700 biopsies, we had 3 bleedings, 2 minor bleedings with just some hematoma at the puncture site, and 1 serious bleeding. So procedural complications are very low in the 0% area. About 211 biopsies of this series fulfilled what we consider a surveillance biopsy, means liver enzymes are not elevated. And we saw on these surveillance biopsies what we could expect from the previous studies, means 1/3 of the patients has no major graft injury in the biopsies, 50 to 60% have any kind of relevant graft injury, 20 to 25% already had advanced fibrosis, and a few already a recirrhosis. Some had steatosis, and really clinical NASH or disease recurrence are minor issues, at least in our cohort here in Hanover. What we then did is to discuss these patients in our interdisciplinary conference. And at the beginning of this program, 80% of the patients had any immediate impact of this biopsy because we changed immunosuppression. A further 20% got any further advices or measurements like lifestyle modifications in case of steatosis or NASH, or some MRCP when we found some unexpected cholestatic problems. Then we all had the problem with the Corona lockdown. Patients didn't want to come into the outpatient department anymore. So we had a follow-up only of half of the patients with a 1 to 2 year follow-up in median 13 months, reaching from 8 to 22 months. I told you we needed a comparator cohort, and we tried to match as good as possible to our follow-up cohort of 112 patients. We were quite successful in terms of age, transplantation, BMI, and kidney function. We had some issues to match for time after transplantation, but as you can see, the majority of the patients were at the later time point after transplantation. We had some problems with historical changes of the use of cyclosporin and more use of tacrolimus in the later years. And as I told you, we had a increasing use of everolimus. This was approved a few years ago. To give you an impression what we did with immunosuppression before we start this structured assessment, we had no changes of the immunosuppression after these surveillance biopsies for research purposes in 80% of the cases. When we reduced the immunosuppression in 60% of the cases after the introduction of the structured program, you can see that we reduced immunosuppression with a wide variety. In median, there was a reduction of 30 to 40%. When we increased immunosuppression in 10% of the patients, the increase was also stepwise in median 20 to 30% when we applied some kind of arbitrary immunosuppression score that tries to measure the overall strength of immunosuppression. We were most afraid of rejection in the cohort where we reduced immunosuppression, and these 69 patients with a cumulative follow-up of 81 years, we had one clear TCMR that was steroid responsive and resolved quite well. We had a liver enzyme elevation in about 6% of the patients. We had 2 deaths with some pneumocystis pneumonia and recurrent PTLD. Immunosuppression was reduced in these patients as a kind of rescue maneuver. We included these patients to show that we did not select the best patient, but give you a true impression of what we did here. And when we look on our historic control, we have a similar range of TCMR and a similar range of patients with any liver enzyme elevations in the follow-up of the biopsy. In these patients where we kept immunosuppression or had to increase immunosuppression, there were no TCMR, as you see, the same background of some kind of liver enzyme elevation noise as in the other groups. When we retrospectively analyzed what we have done in clinical work, we recognized that we were not as strict, or we did not stick as strict to the Banff-Mini criteria as expected. And when we analyzed where we had differences, it was mostly in lobular and biliary inflammation. We have a cohort that is rich of PSC and rich of ischemic type biliary lesion. And if there were just some biliary findings, but without relevant alloy activity, we tend to decrease immunosuppression as well. When the pathologist gives us a scoring between 0 and 1, we usually reduce the immunosuppression. But for this evaluation, we counted 0 to 1 as 1. And we also included patients where we had to reduce immunosuppression as a kind of rescue maneuver, as I told you, for recurrent PTLD. But when we looked at the patients in terms of follow-up, there was no big difference in terms of TCMR rate of elevated liver enzymes, or rate of continued reduced immunosuppression if the patients were within Banff minimization criteria or marginally beyond. The 2 patients that died had any kind of TCMR finding, but in the course of a systemic lethal disease, and they were beyond the Banff minimization criteria. When we looked for a further longitudinal follow-up, just exemplarity shown with the ALT, you can see that we had a slight increase of the ALT. This was significant in the 2nd year after the biopsy, but mostly within the normal range of the ALT. We had a follow-up with liver stiffness measurements only in a small subgroup of patients. Because of the Corona lockdown, the patients were reluctant to come into our outpatient department. When we look on the kidney function, This is shown here as a waterfall plot. You see that patients had a huge variety of changes of their eGFR from the baseline. Some declined, some improved. When we looked on the patient that had a reduced immunosuppression after the biopsy, they had a stable kidney function. Our historic control has a further decline of the kidney function. The difference was significant, and the ones that were kept on the same immunosuppression or even had to increase immunosuppression, they also declined the kidney function in the next year after the biopsy. Next, we only looked on the patients of the ongoing immunosuppression program to get rid of the problems of the historic control. We focused on the patients that had a reduction of the CNI and the patients that had no reduction of the CNI. And as you can see, the difference in terms of kidney function is even more obvious, with a 10 to 12% increase of eGFR and a further 5% decline in those that had no CNI reduction. This was also significant. There were other studies in the literature claiming that reduction of CNI late after transplantation has not a major impact on kidney function. So we compared the patient that had an increased kidney function against the patients with a decreased kidney function after the biopsy, irrespective of the management of the immunosuppression. And what we saw is that the time after transplantation was not significantly different between the two groups, but the major difference between the two groups was the amount of reduction of the overall immunosuppression and most of all of the CNI dose. And the mostly used CNI was tacrolimus in our group. So to summarize the results from this short-term analysis of our personalized immunosuppression program, we can show that we had a very low procedural complication risk, that at least at the beginning of this program, we had a high impact in 80% of the biopsies on clinical management and 80% directly on the immunosuppression management, that a stepwise immunosuppression reduction, no complete withdrawal, had no increased rejection risk in our cohort, even if we violated the Banff minimization criteria marginally, and that we could show a significant preserved kidney function after reduction of the immunosuppression compared to our historic control. We still have to answer if this beneficial effects in terms of persistent low rejection rate and preserved kidney function continues in the longitudinal follow-up after several years. And we still have to show if the reduced immunosuppression might have a beneficial impact on infection and diagnosis of malignancies. The corona pandemic, where all the patients were afraid and stayed at home, is probably not the right time to assess these objectively. And this is ongoing work that we reassess all biopsies, all patients, to see if in the long run we had any further new developments. And we hope that we can present the data in the next 1 or 2 years. And I thank you for your attention.
Well, I'd like to thank Dr. Halloran and Dr. Talbert for their presentations. The next thing up after these recordings is that this will be broadcast in the near future for the audience. And then we will be having 2 live panels, webinars, to be determined, the dates. And they will be focused on different areas of the world and at different times, so that everyone across the world could hopefully find a time to join the webinar and listen to the discussion. And the panelists were chosen based on the locations around the world, just to accommodate that. We really look forward to it. And again, thank you to both of you for your presentations, and we'll see you soon.